presentation will be by Eric Roselli, who was introduced earlier. He's going to talk to us about novel FET for type A dissection.
Thanks, Joe. I've got the video component to share with you. I just want to say thank you first to Morale and David Adams for the invitation to be here. And all the folks in the audience. This has been such a cool meeting. We all sort of share this joy of what we do every day, and it's been really fun to really get in the weeds about all the technical stuff. You may have heard the quote where you talk about kindred spirits, and you say sort of a brother from another mother, and sisters from another mother. But I talk about how I've also got mentors from another mother institution, like Drs. Roselli and Dr. Miller, Dr. Bavaria. And Dr. David, you're sort of a mentor from another mother institution, but not exactly, because you're a Cleveland Clinic guy. And you and I were general surgery residents both at the Cleveland Clinic. I really enjoyed the images the other night at dinner I saw Norm Hertzer and Ed Bevan up there, and of course Toby and the rest of the crew and Bruce and everybody. And so I've always felt a special connection to you because of that, although you were there like right when I was born, I think. Hope I look like you when I'm there. So, but I loved, I always respected and loved what you brought. What I've always learned and enjoyed about my Cleveland Clinic experience is this embrace of innovation. And so thank you for that sort of spirit that I feel. And so I've been asked to speak about something novel that we've been working on, frozen elephant trunk repairs for dissections. What we call the Be Safer or branch stented anastomosis frozen elephant trunk repair technique. Disclosures are shown here. We're studying this Be Safer technique in a physician-sponsored IDE, of which I'm the physician, and it is both off-label and investigational. So this technique evolved over a series of several years. I just saw actually the first frozen elephant trunk I did as a brand new staff back in 2005. It was a Roy Greenberg patient. He had this novel fenestrated stent graft that he put in that a week later showed up with chest pain and a retrograde dissection, and I had to operate on her, and then realized we could sew stent grafts into position and kind of do this frozen elephant trunk thing. And so we did it a whole bunch of different ways. But starting around October of 2015, we started doing it this way, where we put a device in, we cut a hole, and we put a branch in. And that was initially what I called a simplified frozen elephant trunk repair, but then became a branch stented anastomosis frozen elephant trunk repair. We've done over 700 and over 420 within the PSIDE that we've been collecting prospective data on. To sort of be all-inclusive in how we do this, we came up with this classification system to describe it based on sort of the location of the aortic anastomosis and whether we stent, I guess basically the number of vessels that are stented. So it's either single anastomosis, single stent, single anastomosis, multiple stent, multiple anastomosis, single stent, or multiple anastomosis, multiple stent. So it falls into one of those four categories. It's kind of the location of the anastomosis in zone 0 is more of a single anastomosis kind of technique. And if you do the anastomosis in zone 1 or 2, you're going to do multiple anastomoses with a branch to usually the anometer left common carotid. It's been a very versatile approach to treat complex arch disease. The notes on this slide sort of describe a little bit how we choose one technique over another, although we've been able to sort of use this very versatilely. And there's been 15 surgeons within the PSID have been able to do this, and the learning curve seems to be an N of around 2 or 3 cases. So, but I've been asked to show you a video about what we do, and so for frozen elephant trunk with this technique for type A's. The first thing we do is bring the whole team together to make sure we're delivering expeditious care. We have this auto launch network with a radius of about 300 miles for the reach of our helicopters, and we can start caring for these patients before they even show up, make sure we get the images and we plan the diagnosis, we analyze the images, we choose the devices we need to get in place, If a patient's ischemic, we make sure they go to a hybrid operating room so we can do additional stenting if we have to. And when we get there, we've adopted more and more central cannulation techniques like we learned from the guys at Penn and Pittsburgh. It's something like this over a wire. We put a cannula in. We've developed this or devised this very simple technique where we just put a bunch of lure locks in the tubing and we connect 9 French Pruitts for our antegrade brain perfusion. If it's a redo or something more complex, of course, we cut down on the axillary artery. And then here you can see with the cannulas in the branch vessels after we've fully resected the ascending aorta. But we make sure that we leave some arch tissue to sew to because we want to sew that stent graft into place. And here's a video of one of these single anastomosis, single stent B-safers for an acute type A dissection. We happen to be using a Tirone device here. It has the fabric that you can see. We deploy the device. It's very important to secure it in position first before you manipulate it so it doesn't pop out or slide around. I use a knife, not a cautery, to cut this, so I'm not releasing any fluorine gas in the field. And then we stretch the hole and we deliver the branches over a wire. Here you can see I'm delivering a branch into the left subclavian artery and I pull the graft away and I see it. So I'm certain that that wire and that stent are in the targeted vessel, not off along the side of it. We give a little stretch with a cannula. And then we sew the stent graft to the aortic wall. And when we go around here it's in zone 2, when we go around these head vessels, it's not a whole lot of dissection, but a few stitches behind the innominate and left common carotid artery. And then we bring a graft to the field and we suture the graft, again, to stent graft and aorta. And then when we get up around the innominate artery in this location, we just include that right in the anastomosis, and so that's a direct, like an island attachment to the graft. In this patient, we also did a David's procedure, of course. This is a great operation, as we heard all day. Here's another case. This was recent, just a couple weeks ago. This 76-year-old female woke with chest pain, radiating pain, typical kind of presentation. You can see in the video, the arrows are sort of pointing out where you can see the green arrow points to her innominous left vertebral artery come off the middle of her aortic arch, and the red shows a hemorrhagic effusion. So there was some discussion, oh, this is an IMH in this older lady, what do you do? There's not a whole lot of discussion. That effusion is something that you need to understand, that you get an older patient with an IMH, this isn't some sort of thing that you can discuss medical management in. If you get an IMH with an effusion, just like these videos show, it's a contained rupture, so time is short. And so you can see how horrible the flap is. This is not just an IMH. This is a real dissection. It just didn't show up very well on the CT scan. And it also dissected down into her aortic root, causing significant AI. So our plan was to do B-safer for that extensive dissection with central cannulation. Centrally cannulating an ugly aorta, that can be a little messy. But we make sure that we're flowing well in the true lumen. You can see the echo on the right shows we're flowing well in the true lumen. But you can also see in the video here, while I'm kind of dissecting out the arch vessels, the cannula is leaking. I got a sponge around it. It's kind of messy. But we got cold. We were able to get cold. And then we just open the aorta. And we resect the aorta. And then get a good look at the aortic root, get a sense of what we might be doing to that. But make sure that we protect the heart. So we know we've gotten cold, so we're going to protect the brain well. We also have to make sure that we've got the heart protected. We can't ignore it. You see, I'm pointing my scissors more forward, not up into the arch. I've got to leave some tissue to sew this stent graft to. So it is like a location of a hemiarch anastomosis, but we've got to have tissue to sew to. You can't take too much of the lesser curve. And you see inspection in the aortic arch. There's 4 branch vessels there. Her left vertebral artery was a very big left vertebral artery. Then we go ahead and we deliver our stent graft. This is a 34 by 10 centimeter C-tag. In 90% of the cases, we use a 10 centimeter device. We can deliver it over a wire if we need to, but usually it slips in quite easily. My scrub techs have all learned how to deploy this thing. These are on these newer delivery systems where it's a multi-step deployment. In her, we plan to branch 3 stents. So 1 for the left subclavian, 1 for the left vert, and 1 for the left common carotid. We sutured it to the underside, and now we can see the targets, so we can pick the spot on there where we cut the hole. We cut the hole for the left subclavian, and we delivered an 8 millimeter by 5 centimeter left subclavian branch in. Here you can see we're picking the spot for the left vertebral artery. Again, cutting it with a knife, not too big, because it needs to flare a little bit into the aorta, but big enough that we're happy that we're going to get good flow. And you can see after we do that, we deliver a wire in place. We cut a hole for the left carotid at the same time. You got to make sure that the wire goes in easily, and you'll see that in this next video clip. Here we've got a 150 centimeter glide wire that we put in place and a 6 by 2.5 Viabond stent. When I'm pushing on it, I'm getting resistance, so I actually pull it back and rewire it again to make sure that it's something that moves quite easily in and out of that vessel. And then we go ahead and deploy that. And we'll see in that branch with our right to left flow, good return of blood flow through that left vertebral. Now we've got 2 of our 4 anastomoses completed. We then do another one in the left common carotid artery the same kind of way. And we can recannulate these with these 9 French Pruitt balloons so we can maintain our brain perfusion. For the root, we ended up doing a biobental with one of these Connect systems. It looks great. You can see the images on the left show the completion echo. Images on the right shows excellent flow, and that true lumen doesn't collapse at all. We're already starting to get some thrombus in the false lumen of that descending aorta. She did have severe coagulopathy because there was consumption. As that false lumen starts to thrombose, she gets a consumptive coagulopathy. So we left her chest open for a day, but we closed it the next day. And this lady, she was sick, but she was recovering well. She had some renal dysfunction, so we didn't do a contrast CT, but you can see I made a little movie of what the device looks like with the 3 branches. And spins around real cute here. We've got all 3 of those branches fit very nicely. You can see the left subclavion's got some tortuosity. The left vert is open, so is the left common carotid. And so we're able to do a total arch with 4 anastomoses. And the median time in all of these cases is less than 40 minutes. Now, I was asked to speak about this procedure for dissections. You didn't say acute or chronic, but we know chronic type A dissections often show up because sometimes people put a short graft in like this one, or sometimes like a ridiculously short graft like this one, or sometimes we see this giant arch and root that's a mess, and we can't even find where the graft is. I think there's something a little fuzzy in the middle there of this mess, and sure enough, yeah, that's the couple of rings that were attached to some suture material. Maybe it's kind of like that first repair that you showed, Joe. That doesn't really get the job done for these patients. And so we'll often do these multiple anastomosis, multi-stent be safers for chronic dissection patients. Like this one here is a redo, so we had right axillary cannulation. We totally transect the aorta through zone 1, put the device in, and in this one, we put stents in both the left subclavian artery here, and then another stent in the left common carotid artery. So again, very similar technique. A little bit easier to sew the stent graft to the aortic wall because it's flat transected. We're not trying to keep one of the vessels attached. Again, it's really important to look up inside there to make sure that we're satisfied that the stent's going where it's supposed to. I run 2 suture lines, one to attach the stent graft to the aortic wall, and then the graft to complete that anastomosis. We use one of these 10 millimeter side limbs that we tuck behind the innominate vein and got right to the innominate bifurcation, so that in with a 5-0. We also did a David in this patient. Again, great operation. And this is what the completed repair looks like. So our updated results for the annual report that we just submitted, there were 175 acute dissections. You can see the mix of patients. It's pretty consistent, pretty cool. We've got a quarter of the patients are African Americans because we have a big community around us in Cleveland, and they have the usual comorbidities. The breakdown is mostly these single anastomoses. Now more and more we're doing multiple stents, like you can see on the bottom left. Almost half of them are multiple stents. It's just easier to get both left carotid and left subclavian and pull that anastomosis closer to you. The circ arrest time, the median was 39 minutes. And we do these operations pretty quickly. ICU stays 4 days, hospital stays 11 days. And the operative death was less than 9%, disabling stroke 4%, and we're not seeing much paraplegia because we're moving fast, we go very cold, and we use a short stent graft. Marian Koprovanich, this is unpublished, but he did a quick analysis, sub-analysis of 155 of these and found that there were no significant differences with or without malperfusion, despite the fact that obviously malperfusion patients are very complex. Our mortality was under 15% in that subset. So with this technique, it's changed our paradigm of treatment for acute type A dissections. We now are about to be enrolling in the ARISE-3 ascending stent graft trial for some patients who are deemed unfit for surgery, but most of our DeBakey type 1s are done with this Be Safer strategy. We do have the AMDS on the shelf, use that once in a while, and this has been really important as this technology evolves to allow us to handle this complex disease over time. And we have a partnership with the Artivion team to develop a device that will allow us to do this Be Safer operation, the Arcevo device. Hopefully we'll be hearing from the FDA soon and can start the Artisan trial, fingers crossed, later this year. So keep an eye out for it, and happy to talk later. Thank you very much.